This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, I'm here with yet another interesting case. The patient is a 55-year-old lady who presents with clinical picture like this. History reveals that she has undergone surgery 5 years back. She's asymptomatic, but she has come for a drop in vision in this eye. Her best corrected visual acuity is 6/18, the pressure is 14, and she's pseudophakic, and the intraocular lens is peeking out of the pupil. How do you manage this case? The first thing which comes to mind is, we need to consider surgical intervention in this patient. We just can't leave the eye as it is. So if you're wanting to do a surgical intervention, what would be your plans now? We've got multiple options. We can do and just try to redial the lens into the bag or expand the lens and put another lens. But before that, we need to understand the pathology. We need to know why the IOL has popped out of the bag and is into the antechamber. So the answers we get only when we dilate the pupil. When the pupil is dilated, we can see the lens actually has gone back now. But what I can see is a big posterior capsular tear. So probably because of the posterior capsular tear and a question mark vitreous prolapse, the lens has been pushed out of the pupil. So with this clinical scenario, it's imperative that we need to do a surgical intervention. The options would be just try to redial the lens into position, check whether the haptics are in the bag or in the sulcus, and then take a call. And in the worst case scenario, you may consider removing the lens and then placing another multi-piece lens in the sulcus. Of course, after having dealt with the vitreous, if any. So let's proceed with the surgery. The surgery is being done under a peribulbar block. So my first goal is to just visualize the things. Where is the haptic? The pupil is fairly well dilated. I can retract the pupil and see. I'm sure that one of the haptic is inside the bag, but the other haptic, I'm not so certain. Maybe the haptic on my right side. This appears to be in the sulcus. But at this stage, once I put the OVD and push the lens back in, the lens looks to be very well settled. So as I try to remove the OVD, I can see that the vitreous is herniating from under the lens through the side port. So this is one of the reasons why the lens was displaced in the first place itself. So let's try to deal with the vitreous first. So the cutter goes in behind the lens and then I'm doing a limited anti-vitrectomy. It continues for maybe about 5 to 10 minutes and then my job is to just push the lens back. So once the vitrectomy is done and I push the lens back, it looks like it is settling out quite well. And I thought this is a good chance just to leave the lens as it is. So I'm sure that the one lens is in the bag and the other probably is in the sulcus. Of course, there is always a risk of UGH syndrome developing. But because the vitrectomy is done and I feel that the lens would settle back in its place, I constrict the pupil using diluted pilocarpine. And the pupil comes down, the eye looks fine. I thought I got away quite easily. So I just confirmed the absence of vitreous by using triamcinolone acetate. Side ports are hydrated and that's it, the case is done. So unfortunately for me, I had a surprise the next day. Once the effect of the pilocarpine went off, the lens popped out again. Again, the same picture. You can see that there is a edge of the optic of the lens has popped out of the bag and out of the pupil in fact. So part of the lens is in the posterior chamber and part of the lens is in the antechamber. So this was a little bit of a surprise and disappointment both. So the surgical intervention again needs to be done. And this time I don't want to take any chances. I just would want to go ahead and explant the lens. And I got myself ready with a multi-piece lens as well. So I'm going to explant the lens by using the scissors to cut the lens into two halves and then pull it out. The lens in place is actually a single piece hydrophobic lens. I don't know the brand because the patient doesn't have any records. Looking at the design, it looks like the Magnificent lens by the Care Group. One good thing about this is that the lens is very soft. So because the lens is in the human eye and because the temperature is relatively warmer, there's a reason why this lens is quite warm and it could be easy for me to just cut it into two pieces and remove. You can always go and cut it halfway and then swirl it out, but I always prefer to cut it full thickness and pull it out. The chamber is filled with a cohesive OVD, and I'm sitting temporally. I'm going to make a fresh temporal 2.8mm incision to explant the lens out. So the first thing to be done is to maneuver the lens out of the bag into the antechamber. So I'm using Sync to just negotiate the lens out of the bag, and it was not an issue. The lens could be easily negotiated out of the bag, especially the haptic on my left side. The right haptic is always above the capsular bag. It is anterior to the capsular bag. So the lens is now maneuvered out into the antechamber. So OVD is introduced into the chamber. This is a cohesive OVD introduced both in front and behind the lens. The lens is now being stabilized with the second instrument as the scissors is introduced into the eye. While introducing the scissors, I go in with the mouth closed, and it is introduced with both the blades being horizontal. Once it's inside, it's turned vertical, and then the cutting is quite easy because the lens is relatively soft. So 2 cuts are enough to reach the entire span of the lens, and now we have the lens cut. So at this stage I thought, because the cutting was relatively easy, should I venture into cutting the second half of the nucleus into smaller pieces? I venture and then decide there is too much manipulation happening, and because the lens was too soft, the dividing into 3 pieces might not be necessary. So time to explant the lens out. So again, OVD is put. I would like to always pull out the lens where the haptic is curved towards my right side. I'm going to explant the IOL, which is on my right side, because the haptic is curved towards the right side. So it doesn't tug at the wound. That's the reason why it's easier to pull it out. The lens is held with a Durjit Singh lens holding forceps. It's a vertical opening forceps. One can use a McPherson's as well. It just grasps the optic of the broken lens, and then it is pulled out. Similarly, the second half is then again rotated back to ensure that the haptic again is towards the right side, and then it is pulled out of the bag. So the lens is out now. Unfortunately, the pupil has come down. At this stage, I'm not able to visualize the position of the rhexis. So I'm just trying to go in with some BSS, which has got a little bit of adrenaline. Hopefully this is going to dilate the pupil. That is my wish. It's important for me to have a wider dilatation simply because I can visualize where the rhexis margin would be. So now I'm going to introduce again the BSS with adrenaline. I'm just waiting for the pupil to dilate. So it doesn't. So I'm just resorting to using the intracameral agent, that is phenocaine, a little bit, so that it helps in dilating the pupil. So nothing seems to be working now as such. Nevertheless, I'm going to introduce some cohesive OVD. I lift up the iris and place it under the iris and above the anterior capsule so that we have enough space to negotiate the multi-piece lens haptic over the lens capsule. As a rule, as I've been telling before, it's important to enlarge the incision a little bit because in post-vitrectomized eye, the eye would be very soft, and negotiating this cartridge to the 2.8mm incision can be a little bit tricky. There's a reason why enlarging it maybe to 3mm would make the introduction of the cartridge into the antechamber quite easy. The left hand is going to retract the iris so that I can see the rhexis margin, and then the haptic of the lens gently drops above the anterior capsule. Now is the time to deal with the trailing haptic. The chamber is refilled with OVD, and then the trailing haptic again is dialed into the sulcus above the anterior capsule. So I'm just confirming that the haptics are in the sulcus and above the anterior capsule. So I lift the iris up, just check for it, and maybe dial this haptic one more time to just be doubly sure that the haptics are well and truly over the anterior capsule. I'm just trying to retract the iris with my Y hook and then confirming with the dialer that it's above the rhexis margin, because I don't want to get the case back into the OR again. This is already the second time in a week. I want to be absolutely certain that this should be the final surgical intervention, hopefully for this patient. So time to remove the OVD, and I'm going to use the irrigation cannula. I usually go in with a low bottle height in these situations. I'm just going to use a passive irrigation. Press down on the posterior lip and you allow the OVD just to passively flow out. It'll take a couple of minutes, but it's important to evacuate the chamber of OVD as much as possible because this retained OVD can cause pressure spikes in the first post-op day and maybe some amount of inflammation as well. So spending a little bit time to just ensure that the things are looking neat and tidy at the end of a complex procedure is important. Before closing, I'd just like to go in and use my cutter just to ensure that I have not missed out any vitreous fibril. There is a suspicion that there is some amount of a fibril or cortex matter there. So just want to go in with my cutter and deal with it. Looks to be fine now. One more time, last bit of triamcinolone acetate just to ensure that I'm not missed out on any single strand of triamcinolone acetate. So once I'm confirmed that we don't have any evidence of retained vitreous fibril, time to close, time to do the stromal hydration. The side ports are hydrated and antibiotic is placed into the antechamber. That's it, the case is done. These are the first day post-op pictures. The pupil is round and the lens continues to stay in the posterior chamber. So the second intervention with the multi-piece lens in the sulcus worked well and no more troubles for the patient. So that was it. Thank you for watching and I hope you found this helpful.